Anyway, let's get into it. Rachel Rubin. I was just introducing myself again, primary care doctor, interested in mental health, physical health. And I'm just so happy to let you take the stage today, Rachel, because you are an extraordinary person. I am honored to call you a dear friend. And you are changing people's lives, not just women's lives, but people's lives in general by educating them about their bodies, about the importance of sexual health. And I'd love to talk to you today about the genitourinary syndrome of menopause, the value of vaginal estrogen, the importance of addressing sexual health like we do any other aspect of our health. Where do you want to start?
Can I ask? I'm going to start asking you a question because you are one of my favorite people on earth. And this is so easy and natural for you. And my question is, why is this so hard for everybody else? Why do you get it? And you get it easily. As soon as I met you, you got it. And why is it easy for you, but we are struggling so much with many other clinicians?
So I really want you to do most of the talking here, Rachel, but I will say that I consider myself a perpetual student. Like, just because we finish medical school or residency doesn't mean we're done learning. And my whole interest in medicine has always been in the whole person, not just seeing people as a bag of body parts or a collection of organs, but rather as a human being who has relationships with food, with alcohol, with sexual partners. So I've always conceptualized health as more than just your cholesterol and your weight, but rather as the sum total of your integrated parts and how you experience, the world around you. So I intentionally make space for these conversations. And I've learned in 20 plus years of seeing patients that there are many subjects that patients are loath to bring up with their doctors unless you ask. And so when I found again and again and again that when I ask about sexual health, when I've already established a rapport with the patient and it's a appropriate moment, how's your sex life? What's going on? Any erectile function problems or any, people are almost always delighted to answer it. And they almost always give me more information than they thought they were going to be able to give. And when you provide a non-judgmental space and you treat sexual health like any other organ system, you can really help people. It just takes noticing. It's a low bar. It's like, I think I'm a good doctor, but I'm also just paying attention. I think that's what's missing in primary care. It's what's missing in this country is the ability to take time with patients to understand the totality of their health ecosystem. So I don't know if it's me. I think it's more that I take time, and that's what's not available.
And I think that's the magic sauce, right? It's actually time, is meeting people where they are and giving them what they need and actually caring about their goals, not ours. And
Right.
I really do think when it comes to sexual health is I have no idea what kind of sex you're having or what kind of sex you want to have unless you tell me. And so does really become, just like you said, a review of systems. When you and I went to medical school, it was, how do you take a sexual history? It was, do you smoke? Do you drink? Do you do drugs? Do you have sex? Men, women, or both? It was like sex was a vice, like heroin. Like, do you do heroin or do you do sex? And and that's really all doctors are really taught about this. And it becomes, how do we actually move beyond that and bring it of any problems with your eyes, any problems with your ears, any problems with your orgasms? Like, it should be that simple. And I think I come at this from a place of no doctor. I've not had a Lucy McBride doctor. I should probably sign up for your practice. But I have never had a doctor connect with me on that level to care enough about me to actually look at the whole picture and to really connect with me on those issues. And I find that is true for most humans, is no doctor's ever asked you any libido, not just do you have sex, but are you having the kind of sex you want to be having? Are you meeting your goals? Are you optimizing your quality of life? And so I started a practice almost 4 years. Can you believe it? Like, our practices are babies.
I remember when you were hesitant. You're like, is this going to work? Are people going to come see me if I start my own practice? And I was like, Rachel, go, jump off that cliff. And look at you now, girl.
And look at both of us, right? Is to be able to practice medicine in the way that we want, in our own ways. So I started practice almost 4 years ago now, and it has grown tremendously. And I think it is because we are doing authentic, deep care. I joke I'm a sex detective, right? My job is to figure out people and use biology and psychosocial knowledge and use it all to meet people where they are and give them what they need. And it is the joy of a lifetime to get to connect with people. And it's really, I think something about doctors is if your doctor sees 30 patients a day, right? They have to literally be on for 30 patients a day. And every human, I don't know if you know this, but humans are all so different. And everybody needs something different. They need a different tone. They need a different nudge. They need a different sort of personality. And and I was always very good about reading a room. It's something we don't teach medical students very often is how to read a room and try to deeply connect with someone, even though they're not just like you. And I work very hard at that. And so I can't do it 30 times a day. It would literally kill me, right? So I do it, 8 to 12 times a day where I have to kind of meet people where they are. And when it comes to sex problems, if you have pain with sex, if you have low libido, if you're not sleeping, if you have hot flashes, if you hate your partner and you really just need a partnerectomy, we call it, because that sometimes is the solution, we have to be able to figure out and work together so that I can nudge you the way that you want to be nudged, if that makes sense. Like sometimes, and it's not my agenda. It's really what is best for you and where you want to go. And so that's kind of, again, and we can go into all the details because I think this is not uncommon. This is more common than diabetes. This is more common than heart disease. This is more common than hip fractures and osteoporosis. This is the human condition, which everybody suffers from. Every human on earth has sex, wants to have sex, has some relationship to sex, has some idea that they don't want to have urinary problems, that they don't want to have pain in their bodies, that they want to enjoy whatever life that they have. And it doesn't have to be sexual to want to have a functioning body and a pleasurable body and things like that. And so I think it's crazy that there are literally not any fellowships that do this enough to we don't have enough people being trained. And that's part of my mission is how do we educate? Because if your clinician has no idea, right, like they can't give you what they do not have. And so if you have a good doctor like Lucy McBride who can say, hey, I have invested in my education to learn this and I'm working on it. And if I can't give you the answer, go see Ruben down the street. But if your doctor just says, oh, have a bubble bath and a glass of wine, suck it up and just have sex because you're supposed to, that's not helpful or really evidence-based.
Right. Well, let's also acknowledge, and then we'll get to some questions here, that I think doctors are, we're kind of prudish. We're kind of like uncomfortable talking about sex ourselves. As I don't want to generalize, but I say that as a personality type, many of us are not socialized to like talk about uncomfortable things, which is ironic because we are physicians. But I wasn't trained in medical school to talk about mental health. I thought that mental health was for people who were, in a straitjacket talking to the wall and drooling, right? No, turns out we all have mental health. Similarly, we all have sexual health, whether we like it or not. Let's go right to some questions, Rachel Rubin. I know one of the most common questions you get in your practice is what to do if your libido is in the basement. If your libido, your desire for having sex is very low. I mean, I could fill an auditorium with women who say to me on a regular basis, I do love my partner or husband or wife, but my libido is in the toilet. Like, what do you suggest? And this is where a lot of providers say, bubble bath, glass of wine, good luck to you. What do you suggest?
So about 40% of women will identify as having low libido. But if you're like, but are you really bothered by it? Only about 10% will say, yeah, I'm really bothered by it. But 40% have it. So this is not uncommon. This is normal, if you will. But again, if it bothers you, if you want to improve it, I don't like treating people because their partner's annoyed by it. I like treating them because they're annoyed by it. And so if it's something that you want to improve upon, there is a growing toolbox of things that we can do to improve your sex life. What I always like to say is nobody's so good at sex, they can't get better. Like everybody can get better at sex. And so the question becomes, what kind of work do you want to do to get better at sex and have more fun sex? And so it's a little bit of getting to know you. What's your medical history? What kind of medications are you on? What kind of surgeries have you had? How do you feel about sex in general? So it's a bit of that sex detective. I got to get a good history. If you're having pain, why would you ever want sex if it hurts you? How often do you put your hand on a hot stove? You never do it, right? So you could say you love your partner. You could say you want to have sex, but if it feels like raw burning fire every time you try, what's the point? If you're not having pleasure, if you're getting nothing out of it, we have so many people who don't orgasm in the intimacy category. They can orgasm themselves by themselves, but with a partner, it becomes very challenging. So if you're getting no reward, no pleasure, no joy from it, or you're not connecting with your partner, well, that's a problem. Now, there is what we call a biopsychosocial toolbox. Biology, there's a whole lot of biology here. And then there's the things you think about, the date nights, the vacation, the sex therapy, the education, the toys, the fun. And that is so important. The toys, the fun, the sex therapy is important for so many people. But my colleagues minimize the biology, and there is so much biology. So Dr. McBride could tell you very confidently that antidepressants, while often necessary, wonderful, and it can have life-changing ramifications for them, can also have sexual side effects, right? That's a truth. You agree?
Absolutely. It's probably the number one side effect and one of the reasons why people abandon these medications.
Yeah. So when you take an antidepressant, we know that it can lower your libido and it can delay orgasm for men and women. This is true.
Right.
And so that's not to say don't use antidepressants. It's just to say medications, all medications can have side effects, as well as not taking medicines can have side effects. And so we know biology can hurt, like medicines can hurt sexual function. So could medicines improve sexual function? Of course they can, right? It makes perfect logical sense. And we have a toolbox. So we know hormones are very helpful. So if you're having pain and you just use vaginal hormones, which we're going to talk about in a minute, that can make the pain go away, which can then increase your libido, even though it's not working on your brain. We know testosterone is a hormone that works for libido and works quite well. And there's global consensus that it works. Whether your doctor has feelings on testosterone or not is a separate answer, but we know that there's lots of data to show it helps with libido. We know estrogen or whole body estrogen, we know that actually using it through the skin or what we call transdermal, either a patch, a gel, or a vaginal ring, work way better for libido than an oral or a pill form of estrogen. There's a little bit of data to show us that.
I did not know that. You're saying that transdermal estrogen is better for libido, there's the vaginal ring, the fem ring.
So the fem ring is because it's a systemic ring.
Right.
Yeast ring wouldn't be, but yes.
But so you're saying topical transdermal estrogen is better for libido than oral estrogen. That's super interesting.
The reason is when you take oral estrogen, it goes through your liver and it pumps out a protein called sex hormone binding globulin, or SHBG. And when you increase SHBG, it gobbles up your free sex hormones. And so they're not as active. So if you look at the data on sexual function, people who are on transdermal do better. And so if you have a patient and libido's low and they're doing fine on their oral estrogen, sometimes you could just switch them to transdermal and it's drastically helpful. Now, I like sometimes adding testosterone to that as well. But testosterone takes a while. To me, it takes like 3, 4, 5 months before you get that, ooh, it's working. And we do see it. We do see that happen. So hormones are great. Hormones can really help sexual function. When we talk about the reasons to take hormone therapy, no one talks about sexual function. And I think that's part of how prudish we are at not being comfortable as that being a vital sign. But I wish that we act, because the data is very clear that hormones can help sexual function, decrease pain with sex, improve orgasm, arousal, libido, all of the parts of sexual function. And then there's medications that can boost dopamine. So the reason vacation sex is so fun is because you're not stressed, because you don't have the weight of the world on your shoulders, because you have some dopamine around and you're feeling joy and pleasure and you can relax. So medicines that can boost dopamine in your brain, turns out they work pretty well for libido and sexual function. So there's medicines like Addyi or Vyleesi, that are FDA approved for low libido. They work in about 60% of our patients who take them. And then there's the things we've been using before these medicines were available, like Wellbutrin is a common medicine that we've been using to help with libido and also help with kind of depression as well. So we have a toolbox. We love sex therapists. No one doesn't benefit from sex therapy. Everyone can get better at sex by doing sex therapy. We love education. We love teaching people about their body parts, about orgasm, about devices. There's a reason I have a whole bookshelf here full of devices and fun things and clitoris models and vulva models and things to show people, because I love my job because I take the smartest people in the world and I give them very basic facts of this is your clitoris and this is how it works and this is what it does and this is your pelvic floor and this is why you don't orgasm during sex because you're normal. And I teach as I go, same for men too. And just that education can actually improve sex immensely.
So we're talking about HRT, like hormone replacement therapy for women, right? We're talking about the replacing of hormones that the ovaries once were making in robust and consistent amounts, right? Estrogen, progesterone, and then testosterone. What about for men who have low libido? What about for men who are in a loving
So
relationship, but they have no libido or low libido?
So what's so fun, Lucy, is that this is actually the same toolbox, to be honest. So testosterone is our go-to. So if your testosterone is low or low normal, we often will add back some gas in the tank and to help a man's testosterone. Now, women in menopause go to empty gas tank. Men with low testosterone go to like a quarter tank. And when you get that, even a man at a quarter tank, if you get him back up to 3/4 of a tank, you're a hero. I mean, it is dramatic. And so if their testosterone, though, is truly normal, well, then we play with things like dopamine boosting agents. I actually use my I give Addyi and Vyleesi to men all the time. I give Wellbutrin to men all the time, and we do things to boost dopamine in their brain. Don't get me wrong, men absolutely benefit from sex therapy, education, and just normalizing reality, and that's so important too. Is I can't tell, I do a lot of psychourology in my practice where we do a lot of just talking about things, of like me being like, really, because you're the data does not support the thoughts in your head, right? So how do we kind of get over this and work through some of these issues that people have?
I think people are surprised, including someone here on the chat, about testosterone for women. I was taught in medical school, I don't know about you, Dr. Rubin, that ovaries make estrogen and progesterone, and that's about it. When it turns out, ovaries make estrogen, progesterone, and a little bit of testosterone. So when we're talking about hormone replacement therapy, we need to talk about all three hormones.
So time out and testosterone, but
Please.
time out because your ovary makes way more testosterone than it does estrogen. In fact, your ovary needs testosterone to even convert and aromatize to estrogen. It was always the substrate. It was always the thing before the thing. And everyone forgot to tell us. And so when this is actually, let's get a little nerdy for a second. I hope I don't go too nerdy. But when we look at a lab slip, Dr. McBride and I, we see estrogen is in picograms per milliliter. That's how it's written. And testosterone is written in nanograms per deciliter. They're in different units. And so it turns out if you put it all in the same units, we have like 10 times more testosterone in our body than we have estrogen. And interestingly, it's actually not about menopause. There is an age-related decline that happens in testosterone where in your 30s, your testosterone starts to drop. And so what are the symptoms that we see? Low libido is a big one. We also start to see urinary symptoms, frequency, urgency, worsening of leakage, and urinary tract infections that get worse and worse even though you're not in menopause yet. It's because of the drop in testosterone. So you need testosterone for your muscles, for your brain, right? Libido for your brain, for your pelvic floor muscles, and for your bladder and vagina in order to be healthy. And so everyone forgot to tell us this. So your doctor doesn't know. And that's why I yell so much. That's why I mess up coming onto Substack. That's why I yell so loudly, because it's with a little bit of information that people like Dr. McBride can hear and say, oh, that makes sense to me. I'm going to start prescribing it. Like watching you go from what's this crazy lady saying to how do I write the prescription was very quick for you because it made sense in your very smart brain.
So testosterone is still not FDA approved for women, which is bananas. It's actually considered a controlled substance. So, I mean, we could talk about the reasons for that, like why that, but let's talk about testosterone. Okay, it's upside down and backwards, but that's
Right.
cool, Rachel Rubin. I know what you're talking about. Testosterone gel. There we go. Testosterone gel. You're saying, I mean, I prescribe it commonly for menopausal, perimenopausal, and postmenopausal women in conjunction with estrogen and progesterone as part of the HRT hormone replacement therapy kind of kit. And I commonly prescribe it the way you have taught me, which is a little dabble do ya on the back of your calf. Um, but you're saying that women after age 30 start to see reduced levels of testosterone in their bloodstream that can explain a lowering of libido and other symptoms that could be addressed even before menopause.
That's what the data seems to suggest. Now, there isn't enough data for me to loudly say everyone over 30 should be on testosterone. We're not there yet. I would love
Right.
to see it. I just saw a paper I was sending to Kelly Casperson and Mary Claire Haver of people putting testosterone eye drops in and it helps dry eye because there are testosterone receptors in your meibomian
Oh my
gland.
God, Lord have mercy.
And so dry eye is a huge problem that everybody has. And I've been praying for a testosterone eye drop. And now there's some research coming out that people are looking at this. I love that people are looking at this. And so yes, it is. So testosterone is a part of often the HRT regimen, and it may also be a part of the perimenopausal or before full menopause regimen. And it feels serious because, as you said, there's no FDA-approved testosterone for women. It feels serious. It feels scary because we were taught women have estrogen, men have testosterone. But the reality is it's not a feeling. It is like there's data. And when you give people testosterone over time, it helps a little bit. It helps with their skeletal muscle mass. It helps with their stress incontinence. It helps with their libidos. And it is not that dangerous. There's no, like, I'm on testosterone. I'm not bald. I don't have a beard. I don't do laser hair on my face. Like Halle Berry's on testosterone. Kate Winslet's on testosterone. Like these are things that, so it's becoming more commonplace to hear about people using testosterone. But there is no FDA-approved testosterone for women, but it's not because it's not safe. Here's the story, okay? I know you have a lot of smart people listening, so they should hear the history. So
Please.
about $1 billion went into it. There were a couple companies that went to the FDA to study testosterone, and about $1 billion went into it in 5 years of data. And the FDA looked at it every which way, and they said, well, it's safe, it's effective, it works, it's really not that scary, it's not that serious. Ooh, women have breast tissue, so we're going to need 5 more years of data. They wanted a 10-year study, which no company is going to put another $1 billion behind, and because the benchmark changed midway through. They moved the goalpost as they often do. Now, when men, remember I treat men all the time, when a new male product comes out for testosterone, you're talking 6 months of data, about $10 million, and we have like 30 products, right, to give to men. And so we have different benchmarks of what people, sort of how people are doing this. It's a disaster. And the reality is, like, I don't know if we're ever going to get an FDA-approved testosterone product for women. I hope that we do one day, but it's approved in Australia. If it were so dangerous and so harmful and so terrible, why would the Australians have it for decades and decades and decades? And the world's leading testosterone researchers are in Australia because they have a product. It doesn't make any logical sense. And so we also have, and again, I don't care what your politics are, we have data from the trans community, right, where you have 10 times the dose. Okay, you give 10 times the dose of super physiologic testosterone, and it's safe. You're not seeing people drop dead all the time. Like, this is not that serious. We want it. What other medicine do we give at 10 times the dose for decades and decades and decades and watch everybody do fine? So we actually have unbelievable amounts of safety data, 10 times the amount of the medicine. So it feels serious. It's not that serious.
Yeah, I love it. So yeah, I commonly prescribe testosterone. It's transdermal. It's a gel. And obviously the dosing is different for women than it is for men. And importantly, I think this is important, Rachel. You tell me. I check blood levels of testosterone for my women who are taking it, and I use symptoms as a guide as well. Of course, we treat the patient, not the blood levels alone. But with testosterone, I do tend to monitor levels. Is that appropriate, do you think?
Yeah, so the guidelines that we have, and we have both global consensus on that it's okay to do this, and we have ISSWSH, which is a great society, the International Society for the Study of Women's Sexual Health, also put out sort of how-to guidelines, and they do recommend checking a total testosterone level. Now, there's no number of, my testosterone's 30, so I must not have low testosterone. If you have symptoms like low libido and your number is whatever it is, that doesn't mean that testosterone won't work for you or that it's not a testosterone problem. So there's no number. Now, if your testosterone was very elevated, like 200, like then you wouldn't want to start with testosterone or something like that. And I use it just like you. I use it to make sure that they're absorbing the gel and that the number's going in the right direction and it's not crazy, crazy high. But I'll give you there's some, I had a funny patient this week that it's a good teaching case. But basically, I just make sure it's going up and that I tell them that the number's going to go up, but you're not going to fully feel it working for a little bit of time. And everyone's different. Some people 4 months, some people 6 months. Like, I think it takes a little bit of time. But what I see is that patients, and usually these people on estrogen and progesterone already, although sometimes you just start testosterone. And there is a moment where they come back and see me and they say one of two things. They either say, oh, it's working, or they say the magic words, which are, wow, I feel like myself again. that over and over and over again, they come back and they say, wow, I'm back to me. And that's the best thing, right? How could I not want that for everybody? I want that for everybody. So the fun case was I have a patient who is a doctor friend of mine, and she sent me a text and said, ignore my testosterone levels. I promise I don't have a testosterone of 600. I put it on my arm right before they drew the IV off the same arm. And I swear I'm not having a testosterone of 600. I'm going to get put in a repeat lab. I'll get it done again. And so what happened was she put her testosterone gel on her arm. They drew the blood from right there. And so it was super absorbing, like right there. So that's, again, when I see the level of 600, my brain says, I'm not buying it. Let's repeat it. Let's, how did you use this? Let's talk through it.
Oh my gosh, that's an interesting case. That is interesting. So Rachel, how much do you think estrogen helps with libido versus testosterone? Like, you're talking about testosterone for libido, but it's both, it's all the hormones together working in concert, right? So like what I usually do for patients who are suffering from perimenopausal or menopausal symptoms, is I first educate them on the fact that for the vast majority of women, it is safer to be on hormone replacement therapy than it is not to be on HRT if you start HRT in the first 10 years of the last menstrual period. It's not that there's a stop sign at the 10-year mark. It's just that in general, when you start hormone replacement therapy matters, and it's better to start it sooner rather than later. And in general, it's safer to be on HRT than it is to not be on HRT. Of course, there's risk on both sides, but that's what's to be discussed with your doctor, right? I don't actually prescribe oral progesterone oral estrogen. So like I was not aware of the fact that transdermal topical estrogen has a better effect on libido than oral. Um, but anyway, that's interesting. I don't use oral estrogen in general because of the remote but possible risk of blood clotting. But are you saying that testosterone is better for libido than estrogen? Or are you saying it's the cocktail? Are you saying, it's what are you saying? Like what are
Yeah,
we
so
talking about here?
I don't think we have clear data that I can tell you definitively. I can say when my practice, I think of it like a gas tank. If your
Yeah.
gas tank is totally empty and you're not sleeping and you have hot flashes and you're miserable and you all of those things, like I'm going to do estrogen first. Like that to me, estrogen really matters to add some gas back in the tank. I get you sleeping. I get you feeling like not feeling hot all the time. I get you feeling like we get vaginal hormones, so you're no longer having frequency and urgency. We're preventing urinary tract infections. And then I often add testosterone from there. And that I find is the magic where people are like, I feel great, but now with the testosterone, I feel like me. Like I feel like when my partner initiates, I'm on board. I feel like I have sexual thoughts again. I want to masturbate and orgasm again. They have that sort of the little tinglies kind of come back. The orgasm. So testosterone, the clitoris is a testosterone driven organ, just like the penis is a testosterone driven organ. So we find orgasm and arousal are much easier when you have testosterone on board. So I think it is a cocktail and a mixture. That doesn't mean I don't have the occasional 70-year-old patient who comes in and just wants testosterone and we just do testosterone and it works. Like it works when you use it on its own. Or the perimenopausal patient who's fluctuating with estrogen high and low and just has a testosterone problem. So there are times, and it truly is meet people where they are and give them what they need. And it's customized for what's going on with you. That doesn't mean everyone needs testosterone, but it means that everyone deserves a toolbox, right, of different products that they can say, I'd like to try this. I'd like to know more about this one. I'm going to try that one later. And I find testosterone is a magical tool that helps many, many people. Not everybody, but it helps many, many people.
One of the most common questions I get from patients of all ages, women is, how safe is it to take estrogen? My mother had breast cancer, or my grandmother had breast cancer. And, I've talked at length, as have you, about the fact that hormone replacement therapy is not thought to cause breast cancer. That said, there's still this sort of fear in the air about hormones and breast cancer. Can you talk about the risks of systemic hormone therapy? What I'm talking about is hormone therapy at a dose where you're getting it all through your bloodstream and it's hitting all the different receptors in your entire body versus the risks of topical, meaning local, meaning vaginal only estrogen. I know one of your favorite subjects is vaginal estrogen and how it's like saving lives, and I think it is. and when it's appropriate to do systemic estrogen and when it's appropriate to do vaginal and when it's appropriate to do both.
Okay, so there's many things to unpack here. And for anyone who saw in the chat box there, the incredible Lauren Stryker, How Lucky Are We is on, and she is an amazing Substack as well. Big, huge fan of Lauren Stryker, and her podcast is amazing. So, and is a dear friend. And she wrote down there, she said, estrogen reduces the risk of breast cancer. And she's right. So we know from the Women's Health Initiative, which was the big billion-dollar study that scared everyone off hormones, actually, it was never the estrogen that was the problem. Estrogen showed a decreased risk of getting and dying from breast cancer. A new study just came out looking at a medicine called Duave, which is a synthetic oral estrogen, and a medicine called bazodoxifene that showed they were using it in patients with DCIS that showed a reduced risk. And so estrogen, the idea that estrogen causes cancer, it turns out was never true. It wasn't true. So I can't tell you what the risks are because that wasn't what the data was saying ever. And so there are many reasons, that you may be afraid of whole body hormone therapy, and there's the known and the unknown risks. But we have to have a big conversation between the difference between whole body hormone therapy, which is used for hot flashes, for osteoporosis prevention. You may see people talk about it for libido or hair, skin, and nails, or for, whole body feeling good. And then there is microdosing, low dose vaginal hormones, which are miracle drugs. Okay. These are medicines that fix urinary problems, so frequency, urgency, and leakage. They fix sexual problems, so they improve arousal and orgasm and lubrication. And they make sex not painful, and they reduce your risk of getting a urinary tract infection by way more than half. Okay, and this data is very clear and has been around for decades, but we have not had enough implementation. And I think there's a lot of reasons, misogyny, I won't get into the politics here, but there's a lot of reasons. But vaginal hormones are safe for your great-grandmother in the nursing home who's leaking all over herself and going to the hospital with a urinary tract infection.
Yep. And it was cool to see that 2 or 3 weeks ago, the American Urological Society finally came out with guidelines. I mean, the excitement on your face when that was announced, I was like, oh my gosh, this is great. You were part of the reason, by the way, Rachel Rubin. You were part of, if not the reason that this happened. Seriously, let's just.
So this is really important. This is actually really important for your listeners, okay? Science doesn't evolve and change unless individuals roll up their sleeves and do the work. Okay, we all talk about there's not enough. We don't care about women. We're not doing enough research. And so instead of sit around and complain and yell and scream about how everything is awful, I have been rolling up my sleeves and we have been advocating, educating, and researching. And so we published a paper last year that said if women in Medicare used vaginal estrogen, we would save Medicare between $6 and $22 billion per year. Billion with a B, because we would reduce sepsis, we would reduce hospitalizations, we'd reduce mortality, we would reduce all these problems. And because we are vocal about this on social media, we have been picked up by huge, huge organizations and agents. And we're getting the word out there. Now this tube of vaginal estrogen costs $13 on you go to CVS and show them a GoodRx coupon, or you have your doctor prescribe it to Mark Cuban's Cost Plus Drug Pharmacy. It should be covered by your insurance, but this tube is $13. And literally, this will last you about 2.5 months and will reduce your risk of death majorly and help sexual function and make your urinary symptoms completely vanish. But like a sunscreen, it only works if you use it. So if it's in your drawer or your doctor told you to use it, but you didn't, you will get a UTI and all of your urinary symptoms will come back. Now, it's different. When you put this in the vagina, it does not go through your bloodstream. It's very low dose. It's like getting a hydrocortisone cream on a bug bite. It's very different. It's a steroid, but it's very different than IV steroids or an oral steroid medicine. You're microdosing this medicine, but it is enough to restore your bladder health. And you are talking here's the cream. You have to put this much on, like a gram, okay? And you rub it in the walls of the vagina, right? Like you would rub sunscreen on your face and really get it in. So it's not messy. It's not goopy. It's like lotion that you're rubbing in. Many of people are talking about putting it on your face as well to help reduce wrinkles.
It's working already, Rachel.
It is. You can see my face looks incredible. I don't have Botox. But it's true, right? This is not scary stuff. This is low dose medication that prevents UTIs by more than half. And so many couples are suffering. They're getting antibiotics, they're getting resistance, they're getting hospitalized, they're going to urgent care all weekend instead of playing with their grandchildren. I mean, I have personally had family members suffer unnecessarily, and I have never had not talked about this where someone in the chat box hasn't said, my mother, my aunt, my grandmother, my sister has suffered. And the problem is because women think hormones cause cancer, they will not do this. And so it's important. Go on my social media. I have videos for grandma to say, or your mom to say, like, hey, listen to me. I'm a doctor. I know things. And so we advocated for the American Urologic Association to write these guidelines that crystal clear say vaginal hormones prevent urinary tract infections. They help overactive bladder. They do not cause breast cancer. It's written in very clear English. They do not cause breast cancer. Even if you have breast cancer, you should be offered vaginal hormones because we have more data to show you will live longer if you do this than if you don't do this. It's actually
I'm so proud of you.
It's
Rachel,
becoming malpractice. It truly is becoming malpractice by not offering these tools to people.
Rachel, I'm so proud of you. You have worked so hard to educate people, to help people be their own self-advocate in the doctor's office when doctors often don't know the data. They don't understand themselves that estrogen and hormones don't cause breast cancer. I mean, that is just a huge myth that has taken generations to undo, and we're still working on it. So your advocacy and the work of your friends, our mutual friends, doing the work to get people the information they need is changing people's lives. So it's extraordinary.
We go even further. So on my website, rachelrubinmd.com, you go to education, you can literally print out a pocket guide. You print it out and bring it to your doctor's office that says how to write the prescription. It links to our YouTube channel, which has full trainings, both answers your questions and can train your doctor how to write the prescription. Like, we're over this idea that, oh, I never learned how to do this in med school. Yeah, you also never learned how to prescribe GLP-1s, but you're giving everyone a GLP-1, right? And so we have to give them the tools to say, we will teach you how to write the prescription. I give all that away for free because women are dying. Like, this is very serious.
Yeah, I mean, every week I have patients with UTIs, and not all of them are preventable with estrogen, but a lot of them are. And as you just said, people don't know that vaginal estrogen even it should be the standard of care. So
but you want to make sure that you use enough. So my colleagues often say, just take a pea size of this stuff and just lightly put it on the it's not enough. You need a half a gram to a gram, and you want to rub it into the walls of the vagina. So even when people say or if it's on their med list and it says they're on vaginal estrogen and they come in for a UTI, really important to say, how are you using this? Because what you'll find is they say, oh, well, I just had surgery, so I'm not using it. Or, oh, I'm just using a little dab, when I get itchy or something like that, and they're not doing it right. And so the sub-therapeutic, even my patients screw it up, all the time. And so that sub-therapeutic use of it actually is a very easy thing to fix.
Yeah, I had a patient who just had knee surgery, and her surgeon said, you've got to stop taking vaginal estrogen around the time of the surgery. I was like, that makes no sense. I mean, I think what he is thinking is that estrogen increases the risk for blood clots, but we're talking about topical vaginal estrogen that's not systemically absorbed enough and topical doesn't actually increase the risk for blood clots. So that made no sense. It just means that she has to start over, semi-start over.
Not only does it not make sense, but it actually is going to hurt his outcomes because she's going to get readmitted for a UTI. And
right.
So I was texting over the weekend with this amazing, oh my God, I'm obsessed. One of Vonda Wright's friends is an orthopedic surgeon in Duke, and she's a super academic orthopedic surgeon. And we're going to write papers. I'm going to make sure the AUA guidelines get translated into ortho speak. And mark my words, within the next year, we are going to make sure that it is on a checklist of everyone undergoing hip replacement, knee replacement, whatever, pre-giving vaginal estrogen on their checklist. Just they can prescribe a little tablet that they put in twice a week, and I bet you their surgical outcomes will improve drastically. Like, this is where my advocacy is going, because it's not enough for the gynecologist to do this, because why would a woman getting a knee replacement have to go see her gynecologist? It doesn't make any sense. Every doctor who takes care of women should have this on their radar.
I love it. Rachel, talk to us about the difference between Vagifem or Juvafem, the tablet the estrogen tablet that's inserted intravaginally versus the cream. Patients report to me all the time that the cream is messy, it's gunky, so they'd rather have the tablet. When and why do you prescribe the pill versus the cream vaginally?
Yeah. So what's cool is there's like 5 different treatments that you can give someone. I don't have everything in my little toolbox here. So there are tablet inserts, which is a tiny little pill that comes with an applicator that you put it in that you can put it in twice a week. I find this works very well to acidify the vagina to make it go, because what happens in menopause is you lose the acidity of the vagina, so the bad bacteria grow and you have a microbiome problem. And that's why you get urinary tract infections, because the bad bacteria are growing in this non-acidic environment. And so you want an acidic vagina, and the best path there is with hormones. So the vaginal estrogen tablet inserts, I find, are actually very good about acidifying the vagina. Now, sometimes what can happen is that women will have pain at the opening to their vulvas. So if you look inside the labia here, there can be discomfort sort of at the entry point. And so sometimes putting a little cream in that area can be like aloe on a sunburn and can heal the tissue quite well. So an exam can be helpful here, but if your patient thinks the creams are goopy and messy and gross and they won't use them, absolutely the tablet insert is the way to go, because the used product is always better than the not used product. And so if they can't afford it, if their insurance will only cover one type, this is why we have to tinker with the toolbox. So the tablet insert can work great. And sometimes, again, this tube is only $13. So you can put the tablet insert in and take a pea size. You could rub that at the opening sort of every day if you wanted to. So sometimes it's not either or, it's and. There is another product that is one of my favorite that is actually not estrogen, but it's called DHEA. DHEA is the precursor to estrogen and testosterone. And so when you take a suppository of DHEA and every day you put it in the vagina makes it into estrogen and testosterone locally, not enough to raise your libido, but locally to heal the tissue. And so we published on this that it reduces the risk of UTIs, just like vaginal estrogen. We know that it helps for dyspareunia, or pain with sex, we call it. It helps with lubrication, helps with orgasm and things like that. And so what we love about this product is, remember, you don't just need estrogen, but testosterone is an important part of the conversation. And this is an FDA-approved product that adds a little bit of that androgen back. Now, sometimes, would I give it to everyone if I had access to it? I actually would. I would go door to door and deliver it myself if the company let me. But the reality is it's not often first line on insurance companies, which is a disaster. And sometimes your doctor has to do a prior authorization, or they have to ask extra for it. So it's really sometimes prohibitive to get it into our patients' bodies. I work at the VA. It's my pro bono work. I take care of veterans on Wednesdays, and I try to give it to all of my perimenopausal and menopausal veteran patients, because they served our country and I want them to have the Cadillac of products, to be honest. So I get it approved there. But in my regular practice, I do find the inserts tend to be very well covered by insurance. The creams are well covered, but we have to find what works for the patient.
I love it. You're talking about Intra Rosa when you're talking about the DHEA.
Yeah,
Yeah,
it's another prescription product. It's called Intra Rosa.
yeah. I am stymied commonly by the prior authorization, and then it's expensive, and then the patient abandons it. So it's we have a lot more room to move in terms of getting our insurance companies to value sexual health like we do other parts of our health. Rachel Rubin, tell me if you had some parting words for the group here. Like, what are your sort of pearls of wisdom that you want to share with us at the end here? That we haven't already talked about.
So, first of all, the fact that this many people have stayed on for this whole time shows us how hungry people are for this knowledge and their education. If you want to hear me talk about this for 2 hours without taking a breath, I was just on a very big podcast called The Drive with Peter Attia. That is a deep dive into hormone therapy, and the men loved it, the women loved it. It was very well received. And so I encourage you to listen to it, because it really goes into all the details and the whole toolbox. So that catch me on that for sure. I want to tell people that this matters. If you've been listening to this long enough and it matters to you and you've never connected with a clinician that it mattered to them, you're with the wrong clinician. And so you have to see people who care. Now it doesn't mean you're going to have one doctor that does all the things. There is so much. You guys, I don't know how to find a cervix. Like, I'm a urologist. I can't do your pap smear, right? You don't want me to. But the reality is you may need a pit crew. You might need a therapist. I know I do. You may need, a physical therapist to help with the musculoskeletal system and to help with your leakage. You may need a gynecologist. You may need a GI doctor, but you may need a sex doctor. You might need a menopause doctor. You need a pit crew to help you because you're a whole person and you deserve whole person care. So I do 4 things. I'm very boring. I do libido, arousal, orgasm, and pain. Those are the 4 things that I focus on. But if they matter to you, then you should see someone who is obsessed with all of those issues and is up to date on everything we know. And I'll tell you, I wish we had more tools for men's sexual health, right? I've been doing this a long time. I take care of men, and we don't have everything we need for men's sexual health. And yet we're 30 years behind with women's sexual health. And so my mission is, how do we do research, education, advocacy, and mentorship, right, to really legitimize the field of sexual medicine and to say this matters, right? This matters to people. So I just, there is so much excitement in this space. We are inspiring a whole generation of young doctors and young researchers. And it's because we're getting loud and we're talking about it. So when you're at the dinner table, when you're out with your girlfriends, just dip a toe and talk about this stuff, because everybody has these issues and you're totally normal, but you should never suffer unnecessarily.
Rachel, I love it. I'm going to link to the podcast episode you did with Peter Attia. It was amazing. And I think everyone should check out Rachel Rubin's website. It's rachelrubinmd.com. And on there, you can get all these tools that you can print out to take to your doctor. Doctors are still learning too, right? Like, my favorite kind of doctor is somebody who says, I don't know, but let me learn where to find out, right?
And the last thing I'll say for any clinicians that are listening, we are tomorrow launching a course where we will give you the whole playbook. I will teach you how to prescribe hormone therapy step by step. If you like listening to me, that means you're going to hear it better. And I will teach you how to write the prescriptions. We're going to go through cases. We're going to spend time together, and we are going to get you to feel confident. If I can do this as a dumb urologist, you can do this as very smart clinicians that have been doing other things for a long time. It's not that hard. And it is the most rewarding part of my day to transform people. My whole clinic is filled with 50 and 60-year-old women that come to me. And I had 5 of them today that said, Dr. Rubin, sex is great. Work is great. I love my partner. I'm doing fine. Can I have refills, please? And they did not come into me that way, right? And it's so fun to watch that. How can I not want that for everybody? I want that for everybody.
Right. I love it. Rachel, thank you for joining me. I will share this far and wide, and keep up the good work. You're changing lives. You're making people's lives better and healthier. I will talk to you next time, my friend. Thanks for joining me. Bye.
Bye.